The title of this presentation, as Emmanuel has mentioned, is Avoiding Dysfunctions of Supraspinal Lesions. And these are our topics. We're going to talk about the classification of supraspinal lesions, the different patterns of neurogenic lower urinary tract dysfunction for these patients, and I'll cite in the end some examples of supraspinal lesions causing neurogenic lower urinary tract dysfunction. In terms of classification, we know that the supraspinal lesions could be suprapontine or pontine lesions. This is a very interesting illustration which was retrieved from the updated version of the EAU Guidelines on Neurourology 2016 that had been presented before by the other speakers. But in here we can see the most common pattern of lower urinary tract dysfunction in patients with suprapontine lesions. So in the history we have predominantly storage symptoms. The ultrasound usually shows insignificant PVR, and the urodynamics usually shows detrusor overactivity for these patients. As an examples of suprapontine lesions, we can cite the tumors, encephalitis, stroke, head injury, degenerative diseases, Parkinsonism. And as I've mentioned before, we should expect detrusor overactivity, coordinated voiding. So the voiding is right, the timing is wrong, and there is voluntary sphincter contraction. So we should expect coordinated function between the detrusor contraction and the sphincter relaxation. As examples of pontine lesions, we can have multiple sclerosis, multisystem atrophy, Parkinson's disease, and tumors. At this point, I would like to say that I've been discussing with Jalish and most probably isolated pontine lesions due to MS are not usual. Most probably MS may have pontine lesions, but the most predominant factor would be the spinal cord injuries in these patients. Here we have a wide range of dysfunctions, as you can see here in this illustration. We have detrusor overactivity, possibility of detrusor underactivity, uncoordinated voiding, detrusor sphincter dysynergia, involuntary external sphincter relaxation. And it happens, as we've mentioned before, because there are two different areas inside the pontine micturition center, the M and the L regions. Jalish has mentioned it before as well. And this is a very interesting paper showing that the M region, which is called the Barrington's micturition center, is a small region both specific and necessary to voiding and coordination of the bladder and the striated sphincter. But on the other hand, we have the L region, which is less specific area that probably serves as sphincter control in various circumstances, not exclusively micturition. As some examples of supraspinal lesions causing neurogenic lower urinary tract dysfunction, I'll bring some examples here. We'll start with the cerebrovascular accidents, stroke. We know that is the third most frequent cause of death in industrialized countries. 1 out of 200 inhabitants will suffer a stroke. It's more common in patients over 65 years of age. 20 to 30% will still suffer incontinence 6 months after a stroke. And ongoing incontinence is a prognostic factor for poor survival and functional dependence. The lower urinary tract dysfunction after a stroke may be due to the cortical lesions, most commonly after a middle cerebral artery disease, the brainstem lesions, basilar artery disease, and midbrain lesions, the end arteries of this basilar artery. The cortical lesions usually the temporal parietal or the frontal lesions cause some problems. The control over the bladder becomes defective, and it causes the cerebral detrusor overactivity. This is a very interesting study showing the outcomes of 72 patients that presented with LUTS at 3 months after stroke. This is 53%. And as you can see here, urgency urinary incontinence was present in 1/3 of these patients. Urinary tract dysfunction was more common in lesions of the frontal lobe in comparison with lesions of the occipital lobe. And detrusor overactivity occurred in 68% of the patients who underwent urodynamics. There are 2 types of new onset urinary incontinence after a stroke. Usually the urgency urinary incontinence, which is common after frontal lesions. And there is another type of urinary incontinence, which is called impaired awareness urinary incontinence, which is more common after the parietal temporal lesions, as you can see here in this slide. For those patients who survive a brainstem stroke, we have other scenario here. Voiding difficulty occurs in 28% of the patients, according to this study published before by Sakakibara. And the urodynamic patterns of this patient would include detrusor acontractility, non-relaxing sphincter, low compliance, detrusor overactivity, uninhibited sphincter relaxation, here in 3 out of 11 patients. Let's go forward. The Parkinson disease could be brought as another example of suprapontine lesion. At an early diagnosis, the non-motor symptoms would be predominant. And the physiopathology behind the lower urinary tract dysfunction in these patients may be related to problems in D1 and D2 receptors. So we know that D1 receptors have an inhibitory effect on the micturition reflex, and D2 receptors may facilitate the detrusor reflex. So the lower urinary tract dysfunction in patients with Parkinson's disease may be due to too little an inhibition of D1 or too much facilitation of D2, despite of the fact it's not fully understood. We know that the lower urinary tract dysfunction in these patients may be related to the neurological disease, but as Thomas mentioned before, we should think about urological cases for the lower urinary tract dysfunction. So these patients may present with the neurological disease at a later stage during life, and it's not uncommon for these patients to present also with BPH, prostate enlargement, and for women we should exclude cystocele, prolapse, and other causes of urinary incontinence in these women. If you take into consideration the neurological cases of the lower urinary tract dysfunction, we should have detrusor overactivity due to the loss of basal ganglion inhibition, as I mentioned before, obstructed outflow, bradykinesia of the sphincter, and detrusor overactivity also due to the effects of the medication for the Parkinson disease. This is another study published by Sakakibara. As you can note at this moment, Sakakibara has a very, let's say, productive scientific knowledge in our scientific community. And he brought some information about Parkinson's disease patients. As you can see that they manifested the start symptoms in 74% at an early stage. And for those patients who had urodynamics, 82% had detrusor overactivity. But we should also remember that patients with detrusor overactivity in urodynamics may present without LUTS. So at an early stage is not as common as the finding, the urodynamic finding. In the end, MS. We know that symptoms of urinary tract dysfunction in these patients with multiple sclerosis and its prevalence increases with duration of the disease and the extent of the spinal cord involvement. So symptoms occur around 6 years into the illness, and almost all patients report urinary tract symptoms after 10 years or more after the disease onset, as have been published before by Jalish. In these patients, we should have detrusor overactivity due to causing then storage problems, and detrusor underactivity causing emptying problems. For those patients with DSD, it's another problem to take into consideration, and which can bring more difficulties in the clinical management. This study reports the prevalence of urinary incontinence in patients with multiple sclerosis. So out of 403 patients, we had 72% of women, and mean disease duration were 11.8 years, and the mean EDSS was 3.1, respectively. Approximately 35% of patients reported urinary incontinence. So it affects, let's say, more than 1/3 of the patients. As take-home messages, we know that suprapontine lesions usually cause detrusor overactivity without detrusor sphincter dyssynergia. Pontine lesions may present with a broad range of urinary tract dysfunctions, including detrusor overactivity, detrusor underactivity, DSD, involuntary sphincter relaxation, and it's dependent on the affected area in the pons, which may be the M or the L regions. This is my acknowledgement. Thank you very much for your attention, and I'm available for any questions.
Thank you very much, Marcio.